Good morning. Patient first strategy. What do they want, actually, your patients? I'm not sure they're very different than mine. My patient, first and above all, they don't want to have pain. They don't want to have any surgery. They don't want to have stitches. They don't want to see blood. My patient, they would like to have the treatment completed for yesterday. They don't want to come a million times in the practice. I mean, time is ticking. Time is important today. And if possible, they would like to have their treatment for a reasonable price. But above all, and most importantly, and they are right, they want to have successful long-term outcomes in terms of aesthetics, function, and health. So when we look at conventional workflows, whether this is in the anterior or in the posterior regions, with multiple surgeries, with multiple visits, with time for healing, for osseointegration, for provisional loading eventually, can take a long time. It is exhaustive, minimum 6 months, sometimes 1 year. So this is invasive treatment we provide to the patients. Lots of visits, minimum 5, but sometimes a lot more. And of course, all this has repercussions in terms of cost. So now, my dear colleagues, my dear friends, I'd like to move from evidence-based legacy to today's evidence, and with a special emphasis on type 1 timing, immediate implant placement, because this is certainly one of the directions that can help us to answer the needs and the expectations of our patients. And the last consensus meeting, the last ITI consensus meetings regarding immediate implant concluded that immediate implant and immediate loading in the aesthetic zone is predictable and aesthetic with high survival rate when we are in favorable conditions. And what is favorable conditions? And together with my colleague Adam Hamilton and also many other wonderful co-workers, we have tried to put this together in a wonderful book. And one of the most important pieces of this book is a risk assessment table that will guide you to identify which is the ideal patient for a type 1 implant placement protocol. And this is basically decided according to specific selection criteria regarding the soft and hard tissue conditions, the presence of an infection, the presence of the buccal bone wall, and the quantity of bone anchorage that you can get. All these selection criteria are also backed up by today's evidence, and this was nicely summarized in a systematic review that was in preparation of this consensus meeting. Next to today's evidence, we also live in a world where the digital developments are really changing our daily life, and it's also changing dentistry. It is moving fast. And now we have lots of new tools that can really help us developing new opportunities, new workflows, new protocols to treat our patients. And I'd like to start with a case that is summarizing how, based on what we know and what we have in terms of digital technologies, how today I would treat patient with here a failing central incisor. We see that we have a pretty thick soft tissue biotype and a minor recession. So the minor recession might be something that is a little bit compromised, but definitely not a contraindication. So when we remove the crown, we see that, of course, the root is hopeless, not restorable. And putting the DICOM data from the CBCT and the STL from the digital impression, we have now today wonderful tools to plan properly the case and identify if we have the proper conditions to do an immediate implant placement here with no infection, a thin buccal bone plate, but we will deal with that, and a proper apical anchorage for both immediate implant and immediate loading. Then, based on this planning, we can ask for a surgical guide, a static surgical guide, and as well, the provisional crown prior to the surgery. Definitely, guided surgery is part of my daily routine when it comes to immediate implant in the aesthetic zone, because it really helps you to not compromise the ideal implant position when you do an immediate implant. This is here the different surgical steps and the placement of a BLX implant. And following this, very important is the management of the heart tissue with the filling of the remaining socket with a xenograft. And because the case was not fully favorable, I mean, some of the aspects, it was there was a small recession, the buccal bone plate was relatively thin, a connective tissue graft is usually done. And because you have the provisional crown prior to the surgery, you can directly place it in the mouth, and the patient is not a single time out of your chair without a tooth. So this is here after 6 months, and you see that the soft tissue, they heal properly according to the design of this provisional crown that should be idealized according to the digital planning, according to the prosthetic aesthetic setup. So if we summarize the procedure here, of course the extraction has to be minimally invasive. You place the implant in a proper position, and the guided surgery helps for that. We need to have this buccal gap, this remaining buccal socket, and treat the socket with a biomaterial that would be ideally non-resorbable, of course biocompatible and osteoconductive. And in these aesthetic cases, especially when the soft tissue are rather thin or the buccal plate rather thin, a connective tissue graft is recommended. If you have a proper bone anchorage and a proper primary stability, then you can immediately load your implant with a provisional crown. After a few months, when osseointegration is achieved, you can go for the final crown placement, and this is here the result after 2 years. Healthy tissues and peri-implant bone levels that are stable. So, conclusion, invasiveness is definitely here linked to the connective tissue graft, but there is no flap. This is a flapless procedure. Number of visits, it's relatively reasonable, but still this is a few visits. And the cost, of course, there is a provisional, so this influences the cost as well. So we have worked on the validations of these innovative concepts regarding the preparation of the provisional crown prior to the surgery, first with a cemented approach, with the final abutment and a cemented provisional crown. And in every cases, we could place the crown, and we have similar aesthetic outcomes and patient satisfaction outcomes compared to a more conventional workflow. We are also preparing the data for a similar approach regarding screw retain provisional crown, exactly like the case I just showed you. Also, 100% of the crowns could be placed right after the surgery, and only minor adjustment had to be done. Now, how many of these cases do you have every day? I mean, is it what you are doing most of the time in your practice? Or do you have to deal with these situations more often? I would say that this is actually this. I think probably 80% of the case, it's like restoring posterior regions. So now I'd like to move to the possibilities to do immediate implant dentistry in the posterior regions. It was initially introduced in the anterior region, but probably the most impact will come when we have to deal with the posterior regions. And it's important to understand that when we deal with immediate concept, there is like immediate implant placement, and there is like immediate loading. This is two things that we can put together, but this is also concept that we can differentiate. So now when we look at the immediate implant placement, type 1, but with a conventional loading, so type C, looking at the current evidence based on this systematic review, 20 studies, more than 1,000 implants, we see that immediate implant in the posterior region leads to a survival rate of close to 98% when there is a socket filling. And now I'd like to introduce a concept that was actually integrated initially by one of my very good friend, Gary Finel, back in 2017, which is the closing of the socket, of the large socket of a molar with a sealing socket abutment. So like an individual abutment, playing the role of an umbrella, and also, most importantly, playing the role of supporting the soft tissues. So let's look at this case. This case ticks all the boxes for an immediate implant in terms of peri-implant soft tissue environment and bone environment. No infection, apical anchorage, we have a nice septa. And then you see here the whole sequence of the surgery. Of course, always like a minimally invasive extraction. Immediate implant goes with flapless surgery. Implant placement in a proper position, socket filling, and in these cases, we did a digital impression right after the surgery in order to be able to do this custom-made abutment in the lab and place it in the mouth 2 hours later. This is here the outcome after 3 months. Look how the soft tissues are really nicely integrated around these abutment. And then after 3 months, of course, you can proceed with the final restoration with monolithic crowns. And I like this case because you really have the two protocols, you know, the immediate implant with the SSA, and in the second molar position, a more conventional protocol. So this is here the result after 1 year. And because it was part of a study, we also have the CBCT at 1 year, and you see how the bone dimension is very stable. This is here 3 years. Look how nicely we can keep this buccal bulk. And this is the data now that I would like to present you regarding this technique. So this is a case series where all patients were treated with BLX implant, and all these patients received, like 1 or 2 hours after the surgery, these custom-made abutment made of PEEK, and 3 months later, the final crown. We looked at different parameters: implant success, hard and soft tissue profile. And what is very interesting is you see that in terms of the soft tissue profile, vertically, this is super interesting, we almost lose nothing. This is very stable vertically, and we lose a little bit horizontally, less than 1 millimeter. Looking at the hard tissue, very similar. Below the implant platform, there is like no significant changes. There are just minor changes in the transmucosal region. Implant survival rate, based on these case series of 20 patients, we lost actually 1 implant 95%. Peri-implant bone remodeling, very, very little. So basically, this digital workflow in 2 visits, implant placement, IOS, sealing socket abutment. During the osseointegration period, lab procedures, and we were already processing with the final crown. Second visit, after 3 months, placement of the final crown. That was basically the first visit, and the second visit 3 months later. Prosthetic outcome. Aish. We had to do adjustment in 60% of the crowns. So it means that it's moving a little bit during these 3 months. So we do think that adding an additional visit to redo a new impression just after the delivery of the final crown is necessary. So conclusion is, I think a protocol like that is very minimally invasive. You've not seen lots of blood in the slides, right? No stitches. 1 surgery. 3 visits. Cost, well, there is the SSA, the custom-made abutment that has a cost, but we can already reduce the number of visits, so also the cost. So this is a technique that we start building evidence. Now we are actually running an RCT comparing immediate implant with a regular healing and just a little collagen sponge sutured next to it because it's always bigger, and the SSA. I mean, I hope next year I can provide you the data, but what I can already show you is some images, and we're not blind. We see a difference, right? So I think it is a promising technique, and of course the future will tell us if there are a real advantage over like a more conventional design of an abutment, for example. So now I'd like to ask you the question, can we further push the limits? Can we eventually consider the final restoration the day of the surgery? And this is a concept we introduced already a few years ago with my colleague, Professor Amélie Mingeot, from our pros department at the University of Liège. And the idea was to do like a one-tooth, one-time procedure. So basically, in the same day, receive your implant and receive your final crown in full occlusion within the same visit. This is our first patient, almost 10 years ago. So this is a patient that has a missing molar in pretty favorable conditions. Lots of bone, good quality, and the surgical procedure is definitely nothing fancy. This is still a little surgery with a little flap, and here the final crown was made chair side. And as you can see as well, with a titanium base, that it's important to mention, it was not the original, and this will probably influence the result. So this is here the final crown in PICN that you get just 2 hours later, and the placement in the mouth in full occlusion the day of the surgery. This is here after 3 months, after 1 year, and you see here the X-ray over the years, and after 6 years, not much changes, right? So this is definitely a protocol that is quite minimally invasive. Well, we still have several surgeries because she had the extractions before. But regarding the implant procedure, 1 visit. So this reduces considerably the cost. No healing abutment, no custom-made healing abutment. And we went then through a case series with more implants, more patients, and looked at the outcomes based on the 10 patients retreated, all implants survived, but they were like long enough. I was 10 or 12 millimeter, they had a regular diameter. A few prosthodontic complications, especially unscrewing, but we did not screw the final crown at 35 Newton centimeter the day of the surgery. We were a bit scared, but we should have, because we actually got 50% of unscrewing. And when they came back with this complication, of course, we were screwing them to 35 Newton. Timing, 2 hours altogether, and patients that are quite satisfied. Very stable bone levels over the time. And after 5 years, quite some debonding. And you see that the breaking is between the abutment and the glue. So we think that these complications are most likely related to the design of the titanium base that was not very retentive and that was not original. But altogether, we think it's still a very encouraging protocol. Of course, now we think that we should use the original connection, and actually now we don't do it chair-side. We do it in the lab with the proper connection. And case selection is, of course, important. All the cases you've seen were very favorable cases with good bone quality, quantity, proper occlusion, and proper implant size and diameter. And I would like to challenge you a little bit more. Do you think we can go one step further? Because this technique is, of course, still experimental, and we want to see how far we can go. What are the boundaries of that? And I'd like now to come back to immediacy and to immediate implant. And what if we do that in this type of conditions? You know, this is failing premolar, good gingival conditions. We also tick all the boxes in terms of the bone environment, minimally invasive extraction, implant placement in a proper implant position, of course, placement of a BLX implant, proper diameter, 4.5, proper length, 15 millimeter, SL active, socket management, and right after the surgery, a digital impression. Impression is, of course, virtually sent to the lab, and you get this in a couple of hours, the final crown. The final crown is then 2-3 hours later placed in the mouth of the patient, and the patient can go back with a smile. So this is the 1 year, or the 1 week follow-up. So pretty nicely integrated, right? 1 month, 4 months. This is in full occlusion, no? And 1 year. That's a premolar. Let's move to a molar. So here again, good gingival phenotype, no recession. In terms of the bone conditions, this is pretty good. Intact socket, we have an apical anchorage through the septa. We have this nice septa. We have an infection. In fact, infection is not a problem. If this is secluded, if we can clean it, and if it's really inside the bone, and if we can still get a primary stability. So this is here the minimal invasive extraction, and you see how nice is this septa. Actually, you can prepare your implant bed in very good conditions. And the bone would be still there all around your implant. Implant placement, this is here TLX, still an implant that can provide you a proper primary stability. You see that we can reach a primary stability of 35 Newton centimeter. The full procedure, including the socket management, IOS, crown 2 hours later, and 3 hours after the surgery in the mouth of the patient in full occlusion. And this is here the result after 2 months. Invasiveness? Not much. Visit? 1. Cost? Of course, because there is less surgeries, less visits, this is probably less expensive. But still experimental, right? But remember, I had to talk about the future of implantology. And if we have to think patient first, I think yes, the patient, they are driving our behaviors. They are driving our future treatment. We need to address them. And there was so many new development during the last 10 years, and it will continue. I think the conventional concepts are being completely revisited for faster, cheaper, less invasive treatment. And when looking at the future, I think we have a very exciting future. I'm really looking forward for the next 10, 20 years. I think we are going to change the way we are doing implant dentistry. And with this, my colleagues, I really would like to thank you, and I am very much looking forward to build the future of implant dentistry with you. Thank you.